This is a PowerPoint presentation on capnography and end-tidal carbon dioxide monitoring by Michael Day. End-tidal CO2 is the measurement of inspired and expired carbon dioxide, commonly displayed as the partial pressure of carbon dioxide in the patient's airway. End-tidal CO2 can be continuously monitored in both a spontaneously breathing patient and a mechanically ventilated patient. You typically use a nasal cannula for non-intubated patients where one side of the cannula delivers oxygen while the other side aspirates CO2, sending it back to the monitor, giving you the reading. And for intubated patients, it is siphoned in line off the expiratory limb, just off the ET tube. And this can give you continuous readings so you can tell whether or not your patient is breathing adequately. Carbon dioxide is eliminated by the lungs as a byproduct of respiration and metabolism. And so it's used to confirm endotracheal tube placement via the easy cap, which caps onto the end of the endotracheal tube and measures carbon dioxide. This is an example of Nellcore's product called the Easy Cap 2. As you can see underneath, it's got another connection. That connection would connect right onto the end of the endotracheal tube, and your bag mask valve or ambu bag would connect on the other end. Therefore, every expired breath would change this litmus paper from purple to yellow, indicating there is the presence of carbon dioxide, letting you know that the endotracheal tube is properly placed. The aforementioned Easy Cap is placed directly between the ET tube and the bag mask valve. It's basically a simple little device that contains litmus paper. The litmus paper is purple when it comes out of the packaging, which indicates there's no CO2 or less than 0.05% CO2 present. And when you place an endotracheal tube and place it on the end, if it's properly placed and there's exhaled CO2 detected, indicating you've placed the endotracheal tube in the lungs, it changes the color to yellow, and that indicates a successful intubation. I wanted to show you an example of a high-tech EMS paramedic firefighter monitor and defibrillator called the LifePak 15. This does everything. You can defibrillate, you can monitor the cardiac rhythm. In the upper left-hand corner is where you would plug in a microstream line or an inline CO2 detection device, which would siphon back. It's got a little vacuum in there which will siphon out a little aspirated sample to detect CO2 on the exhaled patient. The bottom graph where you see the squares, that is CO2, and if you look at the far right corner of each high note, that is the end-tidal CO2. It's measured at its highest point. The LifePak 15 has microstream and rainbow set technology. What this does is allows for continuous monitoring of four things. Your end-tidal carbon dioxide, which is your end-tidal CO2, traditional pulse oximetry, which is your SpO2, and off of that it has a different set of lights made by Massimo inside the pulse ox. So you're able to get a carbon monoxide reading, which is the SpCO, and a met hemoglobin reading, which is SpMet. This is very important for firefighters and EMS because the presence of carbon monoxide is a bad thing because it blocks oxygen from binding to hemoglobin. Same thing with met hemoglobin. There's certain agents, which we'll cover here in a minute, that can make the iron on the hemoglobin convert from ferrous sulfate to ferric sulfate, which will not allow oxygen to be carried. So if the patient's deteriorating, this gives a quick reading out in the field to eliminate two causes right away. Let's talk about the methemoglobin, or the SP meds. Methemoglobin is a form of the oxygen-carrying metalloprotein hemoglobin, in which iron in the heme group is in the Fe3 plus ferric state, not the Fe2 plus ferrous state of normal hemoglobin. Methemoglobin cannot bind to oxygen, unlike oxyhemoglobin. It's bluish chocolate brown in color. If someone is measured at a really high, greater than 5–10% of methemoglobin, the typical treatment for this is methylene blue, and this will change the ferric sulfate state of the iron back to the ferrous sulfate, which will allow it to carry oxygen once again. Common causes of this conversion of the hemoglobin from ferrous sulfate to ferric sulfate, giving you methemoglobin, are common anesthetics, local anesthetics, anything that ends with cane. So your lidocaine, your benzocaine, prilocaine, acetacaines, also nitrates and nitrites, including nitroglycerin. They all can cause this shift, but be careful when administering hurricane spray or acetacaine spray prior to intubation. This can be a cause if you notice a rapid shift in methemoglobin and trouble oxygenating your patient. This could be one of the reasons why. Okay, let's talk about the numbers. 1 to 2% methemoglobin is a normal value. Typically less than 10% methemoglobin will not involve any symptoms. 10 to 20% methemoglobin, you can get skin discoloration, most notably at the mucous membranes. We're talking about that chocolate bluish. 20 to 30% methemoglobin, you can have symptoms such as anxiety, headache, and dyspnea on exertion. 30 to 50%, you get fatigue, confusion, dizziness, tachypnea, and palpitations. 50 to 70% levels involve coma, seizures, arrhythmias, and acidosis. And then greater than 70%, you're looking at death because there's just not any oxygen going to the body, because oxygen cannot bind to the hemoglobin at that point. So it's very important to treat. Get transported to an acute care facility where they can administer methylene blue. Shifting gears to one of the other parameters monitored on the LifePak 15, we're going to talk about carboxyhemoglobin, or SPCO, and it is from exposure to carbon monoxide, such as a fire or exhaust fumes. Carbon monoxide has the affinity for hemoglobin that's 210 times stronger than oxygen's affinity. So how I like to explain this is if oxygen binds to hemoglobin with the veracity of Elmer's glue, carbon monoxide bonds with the veracity of superglue. So it's much harder to break the bond. Typical half-life is about 4 to 6 hours. The half-life can be reduced to approximately 60 minutes by administering 100% oxygen to a patient. So this is very important if you notice that a patient does have a high carboxyhemoglobin to start oxygen as a treatment right away while transporting to the hospital. The symptoms of carbon monoxide poisoning are as follows: headache, dizziness, weakness, nausea, vomiting, quick irregular heartbeats, chest pain, hearing loss, blurry vision, disorientation, confusion, and seizures. So it's important to notice if a patient does have a headache, they've been vomiting, dizzy, anything like that, or they just don't look right, and they're sitting in the emergency department or they're sitting out in the field, particularly in wintertime around these parts when we just turn on our heaters, or if you have an exhaust problem with your car, it's important to get a measurement, a screening of the carbon monoxide levels and rule that out as a cause, because the treatment, like I said, is oxygen, so it can easily be reversed once it's detected. But if you take another pathway, treating their headache as if it's just a headache, you can delay treatment, and that's a bad thing for our patient. Carbon monoxide levels, 0 to 5% is considered normal. 5 to 10% is acceptable if someone's a smoker. Treat with high flow oxygen and transport to the hospital if you're between 10 to 20%, which is considered high in any population. You can have a headache and shortness of breath in this category. If you have 20 to 30% CO, that's extremely high. It can involve a headache, nausea, and drowsiness. If you're in the 30 to 35% range, that is a critical value. Typically patients are vomiting. They also exhibit the headache, drowsiness. Color won't look right for sure. 35 to 40% can involve the patient just absolutely collapsing and becoming unresponsive. And anything greater than 40% is coma and brain death. So you cannot survive if that much percentage of your hemoglobin is binded with carbon monoxide. Why is capnography important? Capnography can immediately tell a clinician when a patient has stopped breathing or if the endotracheal tube has become displaced. Because it's done on a breath-by-breath action, it's immediate. So you'll know long before a patient's oxygen levels or SpO2 drops. You'll know immediately by that CO2 monitor detecting a CO2 of 0, and it typically correlates with apnea. They usually have both on a capnography monitor, where it'll give you the breath rate and the CO2 reading. So as soon as you see those go blank, you can rest assured the patient either stopped breathing, or if they're an intubated patient, for some reason it's not sensing CO2, so the patient's tube could have become dislodged or entered the esophagus. If it was rattled up and down, it could have come out of the trachea and gone into the esophagus. Therefore, the patient can't breathe. So this is an immediate way to detect things. You can get an immediate reading and acknowledgement that the lack of CO2, where a patient not breathing, or if they've stopped breathing, it could take 30 seconds to a minute before the oxygen saturation begins to fall. So those are the incidents that we're trying to prevent with capnography, is that delay in recognition, delaying care, and potentially an adverse event by waiting on a pulse ox to drop. We don't want a pulse ox to drop if we know immediately that they're not breathing because of the carbon dioxide levels. This is what a normal end-tidal capnography waveform looks like. It goes in 3 phases. Phase 1 is the baseline, which is the patient is not breathing as they begin they breathe in on inhalation, and they begin phase 2, which is exhalation. As phase 2 rolls into phase 3 on the exhalation phase, the very end reading is what we're measuring when you get the number for end-tidal CO2. Then that decelerates back to baseline when the patient begins their exhalation phase, because there's no detection of CO2. So this is what a typical waveform should look like over and over. It should look like this whenever you're monitoring a patient. These are some more waveforms of capnography. This gets a little bit more complex. Figure 7 there, you're looking at capnography waveform that's trending downward, and that can indicate shock. So you see how tall the first wave is, and then it's getting shorter and shorter as time goes on. Figure 8, that's capnography indicating hypoxia, like asthma. It's a little bit more not squared off, it's more of a sharp tooth-like waveform. Figure 9, that's capnography indicating hypoxia due to mechanical obstruction. And you see again the sharp rise in the first wave, and then it gets a little shorter, and that notch is not in there on the second wave. The absence of that notch is kind of what we're talking about, where there might be a mechanical obstruction. Figure 10 is a capnography waveform illustrating emphysema or leaking alveoli in a pneumothorax. Instead of the end tidal part where we had the circle on the previous graph at the very edge of the waveform, you can see it's decelerated. That's because the end reading is not as high as the beginning phase of the exhalation. So these are the minute differences that you can observe based on the type of waveform. Figure 11 is a capnography waveform indicating poor lung compliance. You can also see this in pregnant and obese patients. The end of that end tidal graph rises sharply. That's typically, I think, because of the extra push that they give at the end of the breath, because they're a little bit restricted. That's what the poor lung compliance indicates. So they're having to push out a little extra so they can get their functional reserve capacity to have a fresh breath of oxygen on the inhalation phase. You also see it doesn't go down to baseline there at the end on the inhalation phase. After phase 3, it's above baseline. So that also indicates that they're not the poor lung compliance, and they're not getting back to baseline on the inhalation phase, and they're pushing out on the exhalation phase on phase 3. So these are very, very intricate, minute differences that you can see on waveforms. If you study these, you can get really good at diagnosing a patient based on just the simple exhalation that the patient's doing. Again, sticking with reading these waveforms, we can look at the sudden loss of a waveform in the top left figure. That's where the endotracheal tube has become disconnected, dislodged, kinked, or obstructed, or the loss of circulatory function. So you're rolling along in the first 2 waves. That's a normal appearance, and then all of a sudden you've lost it and more or less flatlined. So it's ceasing to detect any carbon dioxide at that point. So you know something's immediately wrong. That shows you how quick this is compared to pulse oximetry. The second figure, you see decreasing end tidal CO2. The first wave is normal in appearance, and the second one gets quite a bit shorter and less tall. That can be due to an endotracheal cuff leak, the tube cuff leaking, or the tube went into the hypopharynx, or a partial obstruction. So it's detecting some CO2, but the wave looks significantly different than a normal waveform. CPR assessment. You can measure CPR, the effectiveness, because you're attempting to maintain a minimum of 10 millimeters of mercury. So what we're doing is kind of looking at the scale. Typically, if we're doing CPR, we look at the monitor and See if we can get that rise in the QRS complex, so to speak, to know that we're doing CPR correctly. Well, this is another way to do the same thing. If CPR is effective, you're going to probably get at least 10 millimeter of mercury reading. If it's ineffective, you're going to get less than that, not more than that, less. Then moving down to the sudden increase in end tidal CO2. If you're rolling along, let's say at 10 while you're doing CPR, and then all of a sudden you see that rise to 20 or 30. You see the first 3 waves we're doing CPR. At the 4th wave, you see this giant rise. It's about 3 times higher. That's the return of spontaneous circulation, so that's a good thing. That means your CPR worked. Moving to the top right corner, bronchospasm, like asthma or COPD, someone that needs a lot of breathing treatments to open them up, they're going to have that shark fin appearance. So you can see phase 3, actually from phase 2 to phase 3, you get the fin appearance. So that's indicating asthma or COPD. Moving down, the hypoventilation. See how much longer each phase 2 and phase 3, the top part is. And there's a quick drop on inhalation and you're right back up. So that can tell you your patient's hypoventilating quite a bit. On the inverse, the hyperventilation, you see basically very rapid waves. That's the best way to explain that. They're just hyperventilating. And then the decreased end tidal CO2 can indicate apnea or sedation. So we have a kind of a normal first wave, then you go decrease, decrease, flatline, and then back up. So it's very erratic. So if they had an apnea, that would be the 4th wave flatline, and then they take a breath and it would rise back up. So you get a good indication, particularly if you do have a procedural sedation and things like that, where let's say you didn't want the patient to breathe except for mechanical ventilation. You can also look at these waveforms and tell if there's a little spontaneous breaths in between the mechanical breaths to tell if your sedation's even deep enough. Same thing could be said if it's conscious sedation and they're supposed to be breathing but in a twilight, so to speak. A sudden loss could mean they're oversedated, and you definitely need to augment their ventilation artificially. So the product we use for these presentations, the LifePak 15, is made by Physiocontrol. The MicroStream technology is a Medtronic product. The Nellcor EasyCap 2 is made by Nellcor, which is owned by Covidien. It's a pretty standard product used for intubation. The Rainbow Set technology is made by Masimo. That's the pulse oximetry that's able to also detect methemoglobin and carboxyhemoglobin. It's a great product. We use the RAD 57 in the emergency room as a screening tool, but it's incorporated into the LifePak 15 for EMS use.